Welcome everybody to this fifth Anne Klibanski Visiting Lecture Series. I'm Anne Levy, the Senior Program Manager for the Center for Faculty Development, and I'm here today to welcome Dr. Sarah Lensen, who will be talking about IVF add-ons, widespread use of unproven treatment options. She is here from University of Melbourne, Australia, which means we're yesterday to her and she's tomorrow to us. Anne Klibanski Visiting Scholar Award. I think a lot of you know about this, but in case you don't, this was a wonderful program created by our director, Dr. Miriam Bradella, in the wake of COVID, which was disproportionately affecting women. But it was also an opportunity to build on the fact that everybody needed to be virtual. And grand rounds of visiting professorships were being conducted virtually. So to date, we've had 68 women faculty, clinicians, educators, researchers, and postdocs, all with exceptional promise, chosen as Anne Klibanski Scholars to be virtual visiting professors to give a lecture at a national or international institution. They furthermore received mentoring, professional coaching, and leadership training, as well as developing connections with each other. Anne Klibanski, for whom this award is named, is an amazing woman. She was one of our director, Miriam Bradella's mentors. She's president and CEO of Mass General Brigham, and you can read all this other stuff without me having to tell you read it to you. But she has had a stellar career and is a very strong supporter and advocate for women. Here are the scholars that we have welcomed into the ranks. This was the first year's worth, and these are the current ones. And here are all the sponsors, including, I don't know why it's not working for me, but Dr. Lensen's institute is on here somewhere, and it's just not letting me show. Anyway, all right. And this brings up the important point. Because the Scholar program was so successful, we developed a visiting lecture series to offer the opportunity to women who aren't MGH-based to develop their national and international careers. Hence our visit today from Australia, so to speak. It's also a great way for our scholars and other young scholars and other institutions to create relationships and build networking and research opportunities, fostering collaborations across institutions. All right, here we are. And now we talk about Sarah Lensen, Dr. Sarah Lensen, in greater detail. So she is a research fellow at the University of Melbourne. Broadly, her research aims to improve and facilitate evidence-based healthcare of women. She has been involved in a number of large clinical trials evaluating infertility treatment options, including intrauterine insemination and endometrial scratching for IVF. Dr. Lensen is an editor for the Cochrane Gynecology and Fertility Group, and she has published many systematic reviews and meta-analyses. She also has a keen interest in clinical trial and research methodologies. And a little more information for her. She was involved in an international process to establish a core outcome set for infertility trials and a process to develop key priorities for research. Dr. Lensen's current research aims to understand why unproven treatment options are used in reproductive medicine, and to develop evidence-based resources to assist with informed decision-making, which is so very important. So thank you so much for being here, Dr. Lensen. We're delighted to have you, and I'm going to let you take over, and I'm sure you'll do a much more graceful job than I in presenting.
I'm not so sure. Thanks very much, Anne. Thanks for that wonderful introduction. I'll just share my screen, hopefully. Great. Can everybody see my screen or? Yeah, okay, great. So thanks very much. I feel very privileged to be able to speak to you all today, all the way from Melbourne, Australia. And the topic of my talk today is about IVF add-ons. It doesn't add up. Okay, so as Anne mentioned, I am an IVF and infertility researcher. I don't have any clinical role or background. All of my funding for my salary and the research I do has come from university, government, or not-for-profit organisations. So I don't have any financial relationships with any IVF clinics or any commercial companies. I thought I'd just start with a little bit of context for IVF where I live and work. So IVF Down Under, which is a term you might have heard to refer to Australia. So I actually grew up in New Zealand and started my research career there. So in New Zealand, down here, we have access to publicly funded IVF, so free IVF, up to 2 complete free IVF cycles for couples that meet what some have deemed to be rather strict eligibility criteria. And the most sort of controversial is that for couples with unexplained infertility, they have to have been trying to conceive for at least 5 years and still be under the age of 40 to be eligible for public funded treatment. So as soon as these couples have started trying to conceive at age 35 or older, they'll never be eligible. But we do have private IVF available in New Zealand too. And then across the ditch in Australia, the ditch being the Tasman Sea here that separates our countries, the provision of IVF is quite different. So it's almost entirely provided by large private commercial companies, although the government does subsidise about 50% of the cost of IVF back to patients through the Medicare scheme. And almost everyone can access these subsidised IVF cycles. So as long as your fertility specialist deems that you do have medical infertility, you can access these subsidised cycles, and there's no limit on the number of cycles you can go back and have. So you can go back and have 2, 5, 10, 15 subsidised IVF cycles if you wish to. And for these reasons, we do a lot of IVF in Australia. We have one of the highest utilisation rates in the world, or one of the highest uses of IVF per capita. And in both of our countries, the cost of IVF very roughly is about $10,000, which is the equivalent of about 7,000 US dollars. So the topic of my talk today is about IVF add-ons. So these are also known as adjuncts or adjuvants or optional extras. There is actually no established definition, but usually these are considered to be things that are optional or additional to what might be sort of standard IVF. They're normally offered or used with the claim or the hope that they will increase the chance of IVF success. And often that's sort of not further defined. And because they're additional to standard IVF, they also usually come at an extra cost that normally is incurred by the patient. It can get quite confusing because sometimes something that's an add-on on one setting might be routine practice in another. So we see that with things like embryo glue. This is an add-on that some clinics might market to their patients as something they can pay extra for on top of their cycle, and maybe it will help them to get pregnant. And then another clinic might be using embryo glue routinely for all embryo transfers. They don't mention it on their website. They don't mention it to patients. It doesn't even appear in the itemised bill at the end. It's just something that they do for everybody. So it starts to get a bit confusing when sometimes these things are used routinely. I also think that add-ons aren't just those things that might be available at the IVF clinic, like laboratory techniques or medicines or procedures, but also includes things that these patients might be accessing outside the clinic, things like complementary or alternative therapies, acupuncture or Chinese herbal medicine, nutritional supplements like vitamins, special fruit drinks that patients are taking, all these extra things that patients are searching for or possibly being sold with the hope that they'll increase their chance of getting pregnant. So my interest in this space first began when I started my PhD, which was on the topic of endometrial scratching, which is one common IVF add-on. And so this is a diagram of the procedure here, and it's essentially a routine endometrial biopsy or endometrial Pipelle procedure. So the procedure involves placing a thin plastic tube, such as a Pipelle, through the cervix and into the uterus to take a sample of the endometrium, the lining of the uterus. And that sample is taken by an action of suction and rotation within the cavity. And the suggestion is that the disruption or injury or scratch that the mechanical action of that causes might result in the lining of the womb being more receptive to an embryo when it arrives as part of an IVF cycle. So the whole idea of endometrial scratching originated with a team in Israel who were performing these endometrial biopsies on 12 women who had all were experiencing repeated implantation failure. So they'd all had multiple embryo transfers and not conceived. And this research team was taking 4 of these samples at different time points in a natural menstrual cycle to see if they could look at those samples in the lab and try and understand, like, what is it about these women's endometrium that's not allowing the embryo to implant. And then they observed that 11 of these 12 women conceived in their subsequent IVF cycle. And so they thought, wow, maybe it was something about doing these diagnostic procedures that actually has some kind of therapeutic effect. And so that same group went on to conduct this prospective, but unfortunately not randomized study, and that was published in 2003. Where they had a group of 134 women, and 45 of them, they repeated this this protocol of giving them four of these biopsies in the cycle before their IVF cycle. And again, they observed really high implantation rates. So they reported that women who'd had these repeat biopsies, they had double the chance of a pregnancy or a live birth compared to those who hadn't. So this kind of kickstarted the whole endometrial scratching thing. And if we fast forward to 2015, there's now 14 published randomized controlled trials on this topic. But unfortunately, although they are publishing pretty positive results, the quality of the studies is not great. And so collectively, the evidence was reasonably low quality. But our research team was interested to see, well, are people using this procedure? So we conducted an international survey of IVF specialists living in either Australia, New Zealand, or the UK. And we essentially asked them, are you using this procedure in your clinic? And if you are, when and how, and various other questions. But the main finding for us was that over 80% of IVF clinicians were offering or recommending endometrial scratching, and 3/4 of them believed it was beneficial for women with recurrent implantation failure. And the average cost for patients was about 140 Australian dollars, which is about 100 US dollars, so not overly expensive. So because the evidence base was a bit poor for this procedure, but we could see it was being so widely used, our research team thought this was right for a clinical trial. So we conducted what we called the PIP study, which was a randomized controlled trial of women having IVF, and they were randomized to either have an endometrial scratch or not before their IVF cycle. So the study was really pragmatic. So first of all, we had quite broad eligibility criteria. So to be eligible, as long as you are having IVF or a frozen embryo transfer with your own eggs, then you were eligible to take part. And you can't have had any disruptive instrumentation or any procedure inside the uterus that we thought could have had some kind of scratching effect, seeing as that's what we were trying to study in the 3 months before joining, or any other reason why you might not be suitable to have a Pipelle biopsy. And then women were randomized about a month before they planned to start stimulation for their IVF cycle. And if they were randomized to have the scratch, it took place sometime in the month preceding the start of stimulation. So we recruited 1,364 women from 13 centres in 5 different countries. And most of the women were recruited from New Zealand, where we started the trial, where we were running it from. And this is the main table from our results paper, which I suppose the headline result is this top row here for live birth. We observed an identical live birth rate in both arms. So 26.1% of women in both groups had a live birth. And there was also no difference in any of the other, the secondary outcomes that we looked at. And we did note that the procedure was reasonably painful, with women reporting a median pain score of 3.5 out of 10. So this paper was accompanied by an editorial from our colleagues who said, right, it's time to stop using this procedure now. We've got this, this big higher quality study. And it also led to an invitation for a debate in your fertility and sterility journal about, is it time to stop using endometrial scratching? So this really got me thinking, well, this is just endometrial scratching. What about all those other add-ons that I know are out there? Is there any evidence for those? And so I'm not going to say that I went and did a big RCT on each and every one of them, but through our my role as an editor in the Cochrane group, we made recently a special collection where we brought together all the Cochrane reviews that look at various different add-ons and put them all in one place so people can access them together. And I just picked a few to put up today to give you a flavour of what the evidence is generally for a lot of these things. So in the case of time-lapse systems for embryo incubation, if we're talking about whether these increase the live birth rate, this review reports that it is unclear if there's any benefit. They report an odds ratio of 0.91, and you can see a reasonably wide confidence interval there based on 3 randomized controlled trials. So we're not sure if there's any benefit from time-lapse systems for live birth. For the add-on IMSI, or ultra-high magnification for sperm selection, these authors also report they're uncertain if IMSI improves live birth rate. Again, a widest kind of confidence interval there based on 5 studies. For the add-on GCSF administration before IVF, this team also concludes they are uncertain if it improves the pregnancy rate, even though there's 12 randomized controlled trials in this case, and what looks like quite a significant benefit from this procedure. Because the evidence is very low quality, it's Cochrane guidance to not infer too much from the results when we only have very low quality evidence. So this is why this team's still talking about the result being uncertain. And then the last example is endometrial injection of embryo culture supernatant. And this review found 3 randomized controlled trials. And again, you're probably noticing a theme here that these authors are uncertain whether this add-on increases the live birth rate, as the confidence interval again is pretty wide there. So that's our Cochrane special collection. We also published reasonably recently, I think 2019, this series again in fertility and sterility, looking at different add-ons, and we clustered them into whether they were add-ons used in the laboratory, clinical add-ons, or add-ons targeting the endometrium and endometrial receptivity. And broadly speaking, most of the add-ons assessed in each of these reviews were not found to have good quality evidence that they can help people get pregnant and have a baby from IVF. And this series was also accompanied by this opinion piece that was discussing sort of the ethics and possible regulation of these treatments. I just wanted to put up an example on the other side. So it's not all doom and gloom. There are some of these sort of extra options that do have some evidence that that they might be beneficial. So this is the Cochrane review on hyaluronic acid and embryo transfer media, or maybe you might be more familiar with the term embryo glue. So this Cochrane review has 26 RCTs, which is really quite a lot. And they report based on those that embryo culture media probably increases the live birth rate. And that's based on 10 randomized controlled trials and moderate quality evidence, which is really as high as I've ever seen it get, at least in our Cochrane group. So they conclude that, well, when they turn this into the sort of absolute risks, that if the chance of a live birth from IVF normally is about 33%, then for women or couples using embryo glue, then the chance of live birth will be between 37 and 44%. That's what the evidence is telling us. So at this point, we know that there's lots of add-ons available, and there's not much evidence for most of them that they increase the chance of having a baby from IVF. But it doesn't matter. Is anyone using these add-ons? So that was the next thing we went to look at. So we conducted a systematic assessment of IVF clinic websites in Australia and New Zealand to see what they were offering and what they were telling their patients about these things. So when we looked at the 40 different websites or website kind of groups across the two countries, we found that 78% listed one or more add-ons as being available at their clinic. And in total, there were 21 different add-ons available across the clinics. These ranged in price quite considerably, as you might expect from being free, possibly add-ons that are being used in routine practice or part of sort of standard package, up to about $3,700, which is the equivalent of about $2.5 grand in US dollars. And the most commonly advertised website was PGTA, genetic testing of embryos for aneuploidy. This was by far and away the most commonly mentioned at 63% of websites, followed by time-lapse imaging of embryos and assisted hatching. And we also found that most of the time when there was a description accompanying the add-on, that this contains some kind of claim of benefit, whether direct or indirect. So I just put up two examples to show you. So this one's talking about time-lapse imaging and an associated algorithm that helps embryologists pick which embryo. So they say, we use state-of-the-art artificial intelligence technology to assist our embryologists in choosing the highest quality embryo for transfer first time. This can help shorten the time to pregnancy and reduce the number of IVF cycles you may need. And then this quote here, referring to PGTA, says, embryos with the correct number of chromosomes can then be selected for transfer, which improves the chances of pregnancy and the development of a healthy baby. This is the kind of things that patients are reading when they're hopping onto these clinic websites. So this study gave us kind of a good feel for what's out there and what the clinics at least have on their website, but it doesn't really tell us much about how much these things are really being used and which add-ons might be being used more than another, and also things that patients might be using that are available outside the clinic. And because we didn't have any national reporting or national data on this Australia, we decided to turn to the patients. And so we conducted a national survey of women who'd had IVF in Australia in the previous 3 years. And we received about 1,600 eligible responses. And the main finding was that during that 3-year period, so it wasn't, this isn't the data sort of per IVF cycle, but across the 3 years where women might have had one IVF cycle, they might have had 3 or 5. We found that 82% of women had used one or more add-on in that 3-year period. By far and away, the most popular or most commonly used one was acupuncture. So almost half of the women in our survey had used acupuncture, and specifically for the purpose of, you know, at the same time as that they were having IVF. Not that they were using it incidentally and they were also having IVF, but they were using it as part of their IVF process. And then the next two most commonly used add-ons were genetic testing of embryos for aneuploidy and Chinese herbal medicine. So we've really found that the alternative medicines were being really highly used in our Australian group. And as we might expect, a lot of the time the add-ons were costing women extra. So that started from Australia. And there's also two studies more recently from the UK that kind of mirror the studies I just put up for Australia. So this is a review of IVF clinic websites in the UK by this group, and they just looked at these 3 add-ons, not all of the add-ons. And of the 72 websites that they reviewed, they found again a high number, 77% advertised one or more add-ons on their website, and that these were usually accompanied by some claim of benefit. And they reported the median cost of each of these treatments was about the equivalent of maybe $600 US for the first 2, and then almost $3,500 US for PGTA. So these are sort of reasonably substantial sums. And there's also been a national survey of IVF patients in the UK, which was conducted by the HFEA, who are the regulator for IVF in the United Kingdom. And they surveyed women who'd had IVF over a 2-year period. And during that time, about 3/4 of women had used at least one add-on. And the most commonly used add-ons were endometrial scratching, embryo glue, and embryoscope or time-lapse imaging of embryos. And they also noticed that add-on use seemed to be increasing. So when they had surveyed women just in the last 2 years, their add-on use was about 3/4, whereas in the previous 5 years, only 66% of women had used add-ons. So they felt like there was a trend possibly for increasing use of these things. Now, you're probably all sitting there thinking, that's really interesting, but we live in the US, so what about data from our country? So in preparing for this talk, I had a little look to see if I could find many articles on this topic, and I couldn't find very much. So if anyone has any, I'd love for you to send them through to me. But I did find a couple of bits of data. So in 2007, there was a review of websites which spoke about PGD, which included PGTA, but wasn't sort of restricted to PGTA. But more recently in 2009, although that is a little while ago now, this review of clinic websites found that 50% of clinic websites in the US offer PGTA. And in terms of the use of add-ons, again, I could only find data on PGTA from this international report that comes out annually, which reported that in 2013, 7% of non-donor IVF cycles in the US were using PGTA. So we now have covered the fact that there's not much evidence for these add-ons out there, but we can see that they're being widely used, at least in the settings of Australia and the UK. And so the next obvious question I think that a lot of people would come up to a lot of people is why? Why is everybody using these things? So we have a little bit of data from our national Australian survey that I mentioned. So we asked participants, for the add-on that you used most recently, where did you hear about that? And so you can see that 54% of people reported to have heard about the add-on from their fertility doctor. And this was a much higher percentage than any of the other places people might have heard about the add-ons from. And when we subgroup the data based on add-ons that were available at the clinic, there was a much greater proportion that heard about the add-on from their doctor, whereas for the alternative add-ons, specifically acupuncture and Chinese herbal medicine, the most people had heard about these from friends or family. That was the most common source. So it did depend on what add-on we were talking about. We also asked them, when you were at the fertility clinic and the idea of this add-on was raised, who was it that brought it up? Was it you? Was it the doctor or the nurse or someone else? And they overwhelmingly said it was the doctor. The fertility doctor was the one that raised this to me in the setting. And another thing that we asked them as part of the survey was when you're making a decision about using one of these add-ons, how important is it to you that there's scientific evidence for these things? So we asked, how important on a scale of 0 to 100 is it that there's scientific evidence the add-on improves the chance of having a baby and is safe to use? And so people overwhelmingly said it's very important. So the median importance score for effectiveness was about 90, and for safety even higher, with the median score of 100. So this tells us that, you know, patients are telling us that the evidence is very important, but we know that add-ons aren't supported by good evidence, and also that they're widely used. So it's kind of begging the question, like, what is going on here? Maybe patients aren't being adequately informed about the fact that there isn't good evidence for these things. And we've seen that in our review of the IVF clinic websites, where there's lots of claims of benefit being made that aren't usually substantiated. If I just move on as well to a little bit of data from a UK study that hasn't been published yet, but is currently under review. We asked people who'd had IVF in the UK recently about their add-on use and if they were offered or requested any add-ons. And in this group of people, you can see the requests for add-ons were made by about 42% of patients, but many more were offered add-ons. So the rate of offering was much higher than requesting. So that's offering by the IVF doctor or the IVF clinic. And about 67% in our sample had used add-ons. And the most commonly used offered add-ons in this UK setting were time-lapse imaging, embryo glue, and endometrial injury or scratching. And those are the top 3 add-ons from that HFEA report I put up earlier as well. So it is consistent in terms of the add-ons at sort of the top of the list. And this graph also shows us that in every case, the orange bar is a bit longer than the green one, meaning that patients having private IVF in the UK are more likely to be offered add-ons than patients in the public NHS system. So this data is giving us a bit of a flavour for what might be going on in terms of why these add-ons are being used, but to really understand the why of this, I think we have to turn to qualitative research. So this paper was just published last year by a group in the UK, and they interviewed 42 women who all had used add-ons during their IVF process, and all were successful from IVF. So they'd either got pregnant or they had a baby. So it's quite a narrow group in a sense. And they reported that lots of the women in the study reported to be using add-ons because they were looking for the right treatment for them. It was just a matter of trial and error as you proceed through all the different add-ons until you find the treatment that works for you. But on the flip side, they also reported that a lot of women were highly reflective on the fact that they were paying for hope. And they weren't necessarily thinking, oh, there's good clinical evidence that this is going to help me. I know I'm just pursuing this line of hope. And that was particularly the case after experiencing an IVF failure, needing to know that there was some hope to cling to, and the ability to get hope back after that failure. That's what they viewed the add-ons as providing them. And there are these 3 sort of themes that came out of the data. This idea that patients just need to try anything possible that exists, with this woman saying, whatever offers a glimmer of light, you are drawn towards it. And this theme here about accepting the experimental nature of IVF, that the whole IVF process is so mysterious and uncertain, at least from these women's perspective, that the addition of add-ons is just an extension of what is already kind of a big science experiment. So this woman saying, you know, the whole thing is just a bit of a scientific experiment me adding on an additional add-on is just an expansion of what is already an experiment that I'm going through. And this concept here that patients feel like they need to exhaust all resources, every medical option and all of their money before they sort of let themselves give up. With this patient saying, I don't want to not spend that £500 and it didn't work because of that. With this sort of idea that they're avoiding the possibility of future regret, knowing they've tried everything and they gave this thing everything they had. And one interesting thing that this paper talked about, and I should also say this is a really great big qualitative study, and so trying to condense the results into one little slide is not doing it justice at all. It's a really great paper to read. And anyway, one thing that the authors also concluded was that there's a lot of narrative in the literature at the moment about these patients kind of being irrational, using these unproven things, like who would do that? And they talk about the fact that no, these patients are applying kind of rational thinking. It might not be the level of scientific scrutiny that we might use approaching situations, but they are using a version of rational thinking. They're avoiding things that could be harmful. They're asking about whether these things are safe. They're not choosing something to use that they simply can't afford. And when there's sort of a lack of evidence, they're factoring in other considerations that might give an indication about whether something is safe. Like if it's really widely available and it's been around for a long time, that might be a signal that there's not some sort of serious adverse event associated with that add-on. And even more recently, there's been another qualitative research study from the UK again, but this time interviewing UK medical directors at IVF clinics. So this is like the first time, at least in the slides I've put up so far, that the perspective of the clinician has been sought on this topic. And so they interviewed just medical directors, so some of the most senior IVF specialists in the UK. And again, I've condensed a large qualitative study down into just a few of the points that they raised. But it was interesting that a lot of the clinicians were talking about is the fact that the patients are driving the add-on use. And this is sort of in contrast to what we've been hearing from the patients in our data from Australia and the UK, that they're hearing about these things from the doctor and the doctor's bringing it up. And these doctors are saying, for the most part, our perspective is that the patients are driving the add-on use. And they talk about patients seeing themselves as clients, not patients, which kind of leans on the fact that it's such a commercialized, consumerist sort of nature. When you're paying extra for these things, it kind of shifts the dynamic into more of a client rather than patient consultation. And some talked about the fact, well, that IVF clinics, you know, they're competing with each other. They're companies at the end of the day, with this doctor saying, you know, we can introduce that and people will pay for it. There is a market value to it. So it's kind of talking about that, the money side of things. And then there's a really strong tension in this paper in terms of, you know, is it the clinician or the patient who ultimately has responsibility for these decisions? And a lot of these doctors were talking about, you know, the Hippocratic Oath and first doing no harm, and it being the doctor's job to only offer treatments that are safe and effective and do the best by their patient. And on the other hand, a lot of people talking about the fact that these patients are adults. I've given them all the information. We're living in the age of shared decision making. It's not my job to tell this patient what they can and can't have. If they've got all the facts and they're making an informed decision, like that's the patient's prerogative. So we have also recently, well, we're writing this study up at the moment, the value study. So this was a big and qualitative interview standards, a big interview study that we conducted in IVF doctors, embryologists and patients, and we've published the protocol here. And we were exploring in these three groups, sort of similar to the existing papers, the factors that are involved in decision making, how these groups sort of reflect on decisions that they've made in the past, what they see as advantages and disadvantages of add-ons, and also a little bit of information about the UK traffic light. I'm just going to whip through just a couple of themes I plucked out for the purpose of this talk. It's not, we haven't published the paper yet, so they're sort of not finalized, but there's a really strong theme of vulnerability coming through from the patient side with this, for example, this woman saying, you know, I couldn't have cared less. You could have told me the risk was really high. Honestly, I couldn't have cared. If you could guarantee me a baby 100%, I would just chop off my left arm. No worries, I'd just chop it off. And then, you know, this doctor's kind of echoing a similar idea that sometimes these consultations are about desperation. So this person, this clinician, so the red ones are the doctors or the embryologists, and then the blue one are the patients. This doctor says it really turns into a consultation of desperation. The patient has several failed cycles, and that's the point when, if we can improve something or change something without incurring an extra cost, then why not? And then we have the patients talking a lot about these trusted opinions that they really lean on. And this came through a lot in terms of the trust that they place in their IVF specialists, but even in the trust they place in anonymous people posting in online forums. And this person says, you know, that individual story of someone who is similar to me that tried something and it worked, that's a lot more helpful, even though it's just one person, than knowing what happened to 100. When you read that Janet from Birmingham did this and got pregnant, you're like, oh my God, it's going to work for me. And then this doctor's talking about this theme that we call the patient shopper, which kind of echoes the sentiment from that UK study about the patients coming in as clients. And this person says, you know, it used to be the case that the patients would leave their brain at the door and come in and do what they're told. And now I don't think that's the case. They come in through the door, they know what they want, and they've researched it. So at this point, I think we've talked about the fact that there's no good evidence for a lot of these add-ons. They're widely used. Patients are telling us we do really care about the evidence, but then the decisions that they're making to use a lot of these things don't really seem to reflect the evidence. And we know that the information on the IVF clinic websites is probably not fully informing the patients, because we've seen that they kind of seem to speak in a lot of marketing language and inflate the possible benefits of these things. So if there is a problem with the situation, I think it's just about providing information. And so as part of this value study, we were really interested in the HFEA's traffic light website. So the HFEA was the UK regulator, and they have produced this public and patient-facing website that labels every add-on, or they've got 12 add-ons on their website, and they label them with using a traffic light system. So if it's green, it means there's more than one high-quality RCT showing the procedure increases live birth rates. Orange, if the evidence is conflicting, and then red, if there's no evidence. And so we were really interested in this approach, and with a view to trying to deliver something in Australia along these lines, we asked the participants in our study to visit this website and tell us what they thought about it. And so I'll just whip through a couple of the outcomes. Is that people really liked the fact it was simple, but at the same time, that meant it really lacked nuance. And so here we have a patient down the bottom saying, well, is it red because it causes cancer? Then forget about it, I'm not doing that. Or is it red because it just hasn't been tested? Then yeah, I'm happy to proceed on that basis. So it all depends on why it's red. So this person is sort of saying, like, just telling me that it's red is not telling me enough about why it's red. And this clinician here is talking about the fact that we really need more shades of orange. And a lot of people talked about the fact, like, is it orange and it's almost flicking over to green, or is it orange and it's almost red? Because those are very different situations for me, and I might make a different decision in each case. And this clinician in Australia is saying, well, it's particularly for things like PGTA, it's just that something like that cannot be, it's so much more complex. You can't reduce PGTA to one color. It's a complicated decision. And there was a lot of interest in the fact that none of the things on the website were rated green. So of the 12 add-ons that they have on there at the moment, they're all either orange or red. And there's a lot of different viewpoints on that, and things that people took away from that. So this embryologist in the UK sort of speaks to what they view as an overly conservative application of this system, saying, you know, everyone in my field, they just get frustrated by it and they don't even look at it, because you just go, oh, there you go, another one has gone red, what a surprise. And on the flip side, this embryologist says, well, actually, I think it's appropriate that there's no green, because if it's not amber and it works and it's green, then we'd all just be using it because it's effective. And then over here, we have some patients saying, I mean, it just reads like negative propaganda, doesn't it? It's incredibly like, all of this is awful, none of you should be doing it. And this patient's talking about the fact that when they're searching for something new to try, first they'd look at green, then they'd look at amber, and then they'd look at red. So in the absence of any green, they'd be looking first for amber. I'm just going to keep going because I know I'm running out of time. There was also a last theme about the fact that there was not enough depth on the website. And I know I haven't shown you during this talk much about the website, but they don't go into detail, particularly about the number of studies that have been included, or the groups of people that contribute to those. And we had this theme from both sides, from the professionals and the patients, sort of asking, I want to see how many articles are contributing to this. I want to know what the patient population was. Even patients were asking for, I want the hyperlinks to the studies so I can go off to PubMed and look these up myself. So that was really interesting to see just how much detail a lot of the patients wanted. This patient saying, I need information about safety, efficacy, maybe the average cost as well. And this person was talking about the fact, like, surely they know acupuncture is an add-on. Why wasn't that on there? So there's not enough sort of scope at the same time. Lastly, I just wanted to finish by saying that like flipping back to the endometrial scratching story that we had at the start, where in 2015 we showed that a lot of doctors were offering scratching and a lot of them believed that it works. And so we did a follow-up survey in 2020 after we'd published our PIP study, and there'd also been a couple of other large clinical trials published even more recently that showed, again, similar result. That when we redid our survey and we sent it out to the exact same group of doctors across the two countries, we found that the use of endometrial scratching had really dropped. So it's gone from 83% to 34%, which is a drop of about 50 percentage points. And we also noticed that much fewer people now believe that endometrial scratching is beneficial even for recurrent implantation failure, with again a drop of more than 40 percentage points. So I just wanted to put that up to kind of highlight the fact that this industry and the IVF community, that I think they are happy to respond to good quality evidence when we provide it. And maybe that's part of the problem that a lot of these doctors are working in, is that there's not great evidence out there. And so then they're doing the best with what they can. And so I just wanted to kind of end on a high in that sense. And that's the end. Oh, you're on mute, Anne.
Thank you so much. That was absolutely fascinating and brought up the whole, there's such emotion involved in wanting to have a baby, and how can you not take that into account? We do have a couple of questions in the chat, and then I'm sure there will be others. But the first question for you, Sarah, was the PIP study looking specifically for recurrent implantation failure?
Thanks. No, so we recruited anybody who was having IVF, so they might have been having their first transfer or their 10th. But we did try and we increased the power of our sample size, because we had planned to do a subgroup analysis looking separately at these two populations. And I can share with you an analysis we did on that, but because we found no effect overall, there was really no chance of us detecting any benefit specifically in the recurrent implantation failure group either.
Okay, thank you. Amal, if you want to follow up, please don't hesitate. We also have a question from Dr. Jan Schifrin. Did you consider a cost analysis to estimate additional expense for patients and profit for IVF programs?
Sarah, I typed that in before you got to cost information, but I think so you definitely talked about what patients are paying, but you were very polite not to talk too much about profit to the IVF center. And clearly here in the States, we're very concerned about that because I think, as you said beautifully, we could convince these patients to do almost anything and pay almost anything. It's a very frighteningly powerful position to be in. And you talked about infertility, but let me tell you that recurrent loss population. I mean, I'm sure that could be your next review, but, people doing unbelievably dangerous things, injecting white cells from their partner and thousands of dollars for dangerous things. At least scratching is uncomfortable, but it's probably not so dangerous. So that you definitely talked about the cost to patients, but you were very polite and didn't talk too much about the profit to centers. And I think that's really part of it. This is, add-ons make a lot of money for IVF, and IVF now is really lucrative. It's one of the few things in money, along with plastic surgery and dermatology, that's making money and being bought by private equity. I don't know if that's happening in the UK and Australia, New Zealand, but I think one of my partners, reviewed an article. It was like 50% of IVF cycles in this country are private equity. I mean, patients don't know that when they walk in the door, right? But there's a stockholder making money off the profit from her cycle. So it's a morass here.
Yeah. No, I totally agree. We have in Australia, I think most of the companies are owned by big umbrella companies, and they're certainly on the stock exchange, or they have been. I think one of them now has just been bought out again and sold back into private equity. But yeah, and I think it's also complicated because a lot of the doctors say, I'm not making money off of these things. Like, I'm just passing on the small fee, which might not be viewed as small to the patient, but maybe is to the doctor, of what it actually costs me to do this scratch procedure. And I think that in a market where everyone's competing for patients, I think part of the indirect possible benefit of offering these things is like keeping that patient with you, because we hear a lot about the fact that, well, I counsel this patient for 30 minutes about how they don't need this procedure, and then they still want it, and they're just going to go down the road and get it from the clinic down the road if I don't provide it. So, and there's no sense from that person, and they could just let that patient go, because the bum on the seat in their clinic is a profit too. So I think, yes, there's definitely money involved, and I think some clinics clinicians are quite hesitant to really accept that.
Beautiful. I mean, I really loved all the qualitative research, both from the patient and the provider perspective. I thought that was great, just kind of hearing in their own words why they want these procedures or why they offer these procedures. I was really also impressed by that website, but I think as the research on the website showed, it just wasn't granular enough. But I keep thinking, why couldn't the ASRM have the equivalent? All of these add-ons that patients are buying, so it's a patient-facing section, and they look up their scratching or PGT, and it would just be much more. I mean, I don't think you can just have 3 traffic symbols. You'd have to have the papers, maybe little summaries of some of the research, but it could be incredibly helpful. And you'd love to see ASRM put that on their website. But again, I think the 3 bullets aren't that helpful, because most of the things, are going to be somewhere in the middle. So yeah, and I think it's also so interesting that patients they care about safety and efficacy, but they kind of put the 2 together. Whereas when we do clinical trials, they're really separate. So you could have a great patient-facing site for all these add-ons, and it could be really helpful. So thanks for bringing that up.
Yeah, thanks. Yeah, that's what we're hoping. We're just soon about to try and get ethics approval and start the co-design process to deliver something here. So it'll be really interesting what comes out, and we're going to talk to patients and talk to doctors and try and give them something that they both want, and like their doctors would be happy to send their patients to, and so yeah, once we have that, we can share it with the ASRM.
Yeah, I was thinking, so Sarah, are you going to are you doing it with like the big fertility group of that area? Meaning, I think you'd have more buy-in. I think, like, for instance, in this country, if someone wanted to do that, but they started with some ASRM leadership people on that group, you would be much more likely to get it into a place where patients will really see it.
Yeah.
And it will have more, credibility. So I wonder if, since we're at the start of it now, it really may be worth just contacting the ASRM equivalent for, New Zealand, Australia, because I bet they would want it.
Yeah, we have, and they're keen, and so I've got them on this advisory group that I've set up. But we're also so conscious that a lot of the feedback that was coming through during our interviews was like, I love that this website is independent, it's impartial, it's backed by the government regulator. I can trust this because it's not attached to an IVF clinic. And so we're just really conscious of trying to involve the IVF industry here and get all their buy-in and deliver something that they want, and then let their participation sort of stop short of actually the content on the website and saying, well, this thing works and this thing doesn't. So we're kind of trying to come up with a framework there to have it both ways.
Well, you do jobs there to put them on your advisory board. And again, you're not just including, it doesn't sound like you have private IVF clinics. You have, ASRM, should be more of an academic oversight organization rather than, but you're right, you probably want on your advisory board like the biggest private clinics. You want some buy-in from them too, so they share it with their patients. You're right, that's a rock and a hard place. You need to include them because you've got to have everyone at the table if they're going to use it and recommend it for patients. On the other hand, you want to be able to say to patients, we did this based on evidence and we're not influenced by these for-profit companies. It's a bit of a dance, but it sounds like you're doing a bit
yeah. Thanks.
We have run out of time, but we could keep talking forever. I mean, the whole issue of trust is so key here, and what a patient is ready to trust or not based on the patient's own desperation. There's so much subjectivity, but that's the heart of being a parent. Thank you so much. You've gotten some very positive feedback, Sarah. Informative, interesting, great. And I agree 100%. I'm not a doctor. My PhD is in American Studies, but as a mother, I can certainly understand all that's involved. I've had many friends who've had to go through IVF. So thank you. So we wish you immense luck and good fortune with your research, which is so important, and hope that you create strong connections to the MGH community. And thank you everybody for coming. Enjoy the rest of your day. It's absolutely gorgeous here, and I hope it is in Melbourne as well. Thank you.
Thanks so much,
Sarah. It was really great.
Bye.
Thanks, everyone.
So glad my meeting ended early. Terrific.
Yeah, thanks, Jan.